on Dr. Neha. She will be talking on a paper which is relevant to liver abscesses. Dr. Neha, please.
Good evening, everyone. Myself, Dr. Neha, from third year General Surgery PG from MVJ Medical College and Research Hospital. I'd like to thank President and Secretary of Surgical Society and Dr. P. Sudarshan, HOD and Professor of Department General Surgery, who has guided me for this paper, e-paper, which is on a prospective study on incidence, etiopathogenesis, clinical presentation, management, and prognosis of liver abscess. Coming to introduction, liver abscess continues to be a major diagnostic and therapeutic challenge to the medical fraternity, life-threatening and potentially serious condition if left untreated, so important for prompt diagnosis and appropriate management at the earliest. Two common types of liver abscess encountered are amoebic liver abscess and pyogenic liver abscess. Amoebiasis is a common manifestation in developing countries due to poor sanitary facilities, affects about 10% of the population all over the world. Amoebic liver abscess is the commonest extraintestinal manifestation of amoebiasis. It affects about 3 to 9% of population. India is an endemic zone for amoebic liver abscess, may present as acute abdomen requiring emergency laparotomy. Spontaneous intraperitoneal rupture, extra and retroperitoneal rupture, and intrathoracic rupture are frequently seen in liver abscess. Delay in diagnosis may lead to rupture of liver abscess, which may increase the morbidity as well as mortality. Pyogenic liver abscess is not an uncommon entity. It is a relatively rare complication of intra-abdominal infection or biliary tract infection, usually polymicrobial in nature due to the ascending route of infection from the gastrointestinal tract. Overlapping of symptoms between amoebic and pyogenic liver abscess makes early clinical differentiation difficult. Study was conducted to assess the incidence, etiology, clinical presentation, management, and prognosis of liver abscess in patients attending a tertiary referral hospital. My aim set objective of the study was to study the incidence and etiology of liver abscess, evaluate the clinical features of liver abscess, evaluate the management and prognosis of liver abscess, materials and methods of the study. This is a prospective observational study was conducted analyzing 99 patients in MVJ Medical College and Research Hospital from November 2020 to November 2021. All patients admitted to the surgical ward with liver abscess. Inclusion criteria were patient admitted in general surgery wards of MVJ Medical College and Research Hospital confirmed to be of liver abscess. Exclusion criteria was hydrated cyst of liver and primary and secondary malignancy of liver. A total of 99 cases satisfying the inclusion criteria were recruited in this study. Here we can see in the first picture, there are multiple liver abscesses in the right lobe of the liver with hypoechoic space occupying lesion in the right lobe of the liver with multiple internal echoes. In second picture, we can see the solitary liver abscess in the right lobe of the liver, a hypoechoic collection. In the second picture, which is a CT scan of the abdomen and pelvis, we can see a hypoattenuating lesion in the right lobe of the liver. This X-ray of posterior anterior view of the chest showing the elevated right hemidiaphragm due to the liver abscess. Coming to the results, age incidence of liver abscess, in age group of 30 to 40 years, 16% of patients were affected with the liver abscess. 41 to 50 years, 48% of population was affected with liver abscess. 51 to 60 years, 20% of patients were affected with liver abscess, and more than 60 years, 15% of patients were affected with liver abscess. In sex distribution, 98% were male affected with liver abscess and 2% female affected with liver abscess. Coming to history of alcohol intake in the liver abscess, 97% patients were having in amoebic liver abscess history of alcohol intake, whereas 33% of patients in pyogenic liver abscess have history of alcohol intake. Symptoms in the cases of liver abscess, most common symptom was abdominal pain, which was 44%, following fever, which was 26%, abdominal distension 23%, and dysentery 7%. Coming to the clinical sign, most common clinical sign was 35% of right hypochondrial and intercostal tenderness, following hepatomegaly, which was 17%, jaundice 9%, and 4% epigastric mass. Lobe involvement in the liver abscess, most commonly involved lobe was right lobe of the liver, which was 80%, following left lobe, which was 19%, and the incidence of multiple abscesses were 5%. Etiology of liver abscess, the most common cause of liver abscess was amoebic, which was 91%, following pyogenic, which was 9%. Mode of treatment of liver abscess, Single percutaneous needle aspiration was done in 30% of patients. Percutaneous catheter drainage was done in 25% of patients. Laparotomy and drainage was done in 22% of patients. Multiple aspirations were done in 19% of patients, and conservative management was done in 3% of patients. Here is a picture showing the procedure which is done for the percutaneous needle aspiration of amoebic liver abscess, showing anchovy auspus. Here is a picture of ultrasound guided percutaneous needle aspiration of liver abscess. The pigtail catheterization done in a patient of liver abscess. Here is a picture of laparotomy done for the complicated liver abscess, showing a soft and fluctuant mass. Here, second picture can be seen as a case of ruptured liver abscess, which is seen during the laparotomy. Discussion: liver abscess continues to be one of the common liver disorders, even in the era of improved sanitation and personal hygiene, as well as availability of wide range of antimicrobials and antibiotics. Annual incidence of liver abscess is 2.3 cases per 1 lakh population, higher among men than women. More common in right lobe of liver. Increased incidence in alcoholics, diabetes mellitus, immunocompromised status. Causes 13% of total intra-abdominal abscesses. Pyogenic liver abscess, mostly seen in patients in their 50s to 60s, often related to biliary tract disease and cryptogenic in nature. Incidence of pyogenic liver abscess is 22 per 1 lakh hospital admissions, with male is to female ratio 1.5:1. Comorbid condition associated with pyogenic abscesses are cirrhosis, diabetes mellitus, chronic renal failure. Fever, chills, and abdominal pain, most common presenting symptoms, with right upper quadrant tenderness is the most common elicited sign in both pyogenic and amoebic liver abscess. Percutaneous drainage combined with broad spectrum antibiotic has become the first line and mainstay of treatment for most pyogenic liver abscess. 40 to 50 million people suffer from amoebic abscess, resulting in 40,000 to 1 lakh deaths each year. Amoebic liver abscess common in 20 to 40 years of age group with a history of travel to endemic area. Male is to female ratio 10:1. Predisposing factors are immunosuppression such as HIV infection, malnutrition, and chronic infection or chronic steroid use. Mainstay of treatment amoebic abscess is anti-amybicidal plus luminal agents, and amoebic abscess, if carry a risk of rupture, aspiration or percutaneous catheter drainage to be considered. Mortality in 5 to 30% of cases. Most common cause of death includes sepsis, multi-organ failure, hepatic failure. Factors independently associated with poor prognosis are elevated serum bilirubin level more than 3.5 milligram per deciliter, encephalopathy, hypoalbuminemia, which is less than 2 gram per deciliter, multiple abscess cavities, abscess volume larger than 500 ml, anemia, and diabetes. Conclusion: liver abscess constitutes 0.29% of total surgical ward hospitalizations per year. Liver abscess commonly seen in the age group of 41 to 50 years. Male predominance is 97.9% was seen in liver abscess. Nearly 2/3 of cases of liver abscess had a history of alcohol intake. Majority of liver abscess were amoebic and nearly 10% were pyogenic. Escherichia coli was the commonest organism causing pyogenic liver abscess. Abdominal pain was the commonest symptom, followed by fever and abdominal distension. Right hypochondrial tenderness and intercostal tenderness are common clinical sign. Predominant involvement of right lobe of liver. Percutaneous aspiration of abscess with anti-amoebic antibiotics forms a mainstay of treatment, followed by percutaneous catheter drainage is a method of choice in failed aspiration, and laparoscopic drainage or laparotomy drainage is indicated in ruptured liver abscess. These are my references. Thank you.
Sunil sir, if you have any questions. Sunil sir.
Dr. Neha, good presentation.
Thank you, sir.
You had some laparotomies in your series, is it?
Yes, sir. Yes, sir.
What were the main indications for those laparotomies?
So indications for the laparotomy in the cases of ruptured liver abscess, either there is the features of peritonitis is present, or the features of rupture in the pericardium, which leads to pericardium tamponade, or if the rupture in the
Basically, it is ruptured.
Yes, sir. Yes, sir.
All were ruptured because one photo you showed, which was
Yes,
not
sir.
ruptured.
Yes,
That's
sir.
why we just
Yes,
asked.
sir.
And you also concluded that you had many patients with fevers with chills and rigors.
Yes, sir.
Why I'm asking this is recently not many people come with classical symptoms of fever, chills and rigors, intercostal tenderness. Those are gone, that's right. But you concluded it is one of the main components in your patient.
The most common symptom is abdominal pain followed by fever and chills, sir.
Chills were there. Okay, fine. Did you do culture sensitivity of the pus, which was brain?
Yes, sir.
Means to quote it as amoebic, were there any other tests done, or it was bacterial versus amoebic?
Sir, it was bacterial versus amoebic, sir.
Okay. Any deaths in your series?
No, sir.
Okay. Okay. Okay.
Yeah, Neha, good presentation. Yeah, thank you, sir. You mentioned about pyogenic abscess in your case.
Yes, sir.
Can you tell me what was the most common cause of pyogenic abscess in your series?
So most common cause was biliary cause, sir, because of the presence of cholangitis and due to intrahepatic stones sometimes, and followed that some patients presented with the features of diverticulitis and inflammatory bowel disease. So that lead to the pyogenic abscess secondary to it.
So these were the causes in your series.
Yeah, yes, sir.
Okay. So was there any lesion in the posterior aspect of the liver? And if so, how did you approach it? You just mentioned about the right lobe and left lobe involvement.
Yes, sir.
Did you comment about the anterior or posterior aspect of the liver being involved? Because the approach to the posterior lesions is different.
Yes, sir. So the segments affected in the series mostly was seen was posterior superior segment of the liver, which was mostly involved, sir. So
Okay.
for that, like the multiple patients which we have seen, it was posterior superior. Some patients presented in the segment 4 also.
What was your approach for posterior superior lesions?
So pigtail catheterization was done for those patients, sir.
Percutaneous.
Yes, sir.
Okay. Any other approach which you are aware of? Fine. Any recent advances in the management of liver abscess? You spoke about the open technique, the percutaneous technique, the laparoscopic technique. Any recent methods? Fine, never mind.
Okay.
Thank you.
Thank you, sir.
So the next paper will be presented by Dr. Akhila. He is also finally a postgraduate. Giemsa staining of Helicobacter pylori infection in peptic ulcer perforations. So in MVJ, we do get a lot of peptic ulcer perforations, and most of them are pre-pyloric. She will be talking to you about that. Introduce yourself, please, Dr. Akhila.
Good evening, everybody. I'm Dr. Akhila, final year postgraduate from Mvjmc. Today, I'll be discussing Giemsa staining of Helicobacter pylori infection in peptic ulcer perforation. Acid-peptic disease is a very common disease in India, and most common complication of this is perforation. Acid-peptic disease continues to enact a heavy toll on the patient's personal and financial aspect. Recent epidemiological studies have shown increase in the incidence of peptic ulcer perforation. Perforation has a poorer outcome such that conservative therapy is not recommended. Surgical intervention is the mode of treatment. Of these, the increasing use of NSAIDs, aspirin, smoking, and many whom may have Helicobacter pylori infection. This bacterium forms one of the most important etiological factors for the acid peptic ulcer perforation. Several studies have revealed the association of Helicobacter pylori in 70 to 75% of the patients with dyspepsia. Perforation of gastric or duodenal ulcer is one of the most serious complications. The perforation and the resultant peritonitis are immediate threats to life. The ulcer in itself is not. The therapeutic priorities thus are treatment of the peritonitis and securing the closure of perforation, which may be achieved with surgical procedure. Prompt recognition of the condition is very important, and only by early diagnosis and treatment it is possible to reduce the still relatively high mortality. The aims and objectives of my study was to evaluate the Helicobacter pylori infections in patients with perforated peptic ulcer presenting to our center, and to study the use of Giemsa staining method to identify Helicobacter pylori organisms. The definition of my study subject were all the patients who presented with peptic ulcer perforation admitted in the surgery department from November 2019 to October 2021. It is a prospective study involving 30 patients, with patients being diagnosed with features suggestive of peptic ulcer perforation. The study was conducted over a period of 24 months. Data was collected after meticulous history taking, careful clinical examination, appropriate radiological and operative finding with biopsy and staining with Giemsa stain, and follow-up of patient after fulfilling the inclusion and exclusion criteria, and those who have given written informed consent. All patients presenting with features suggestive of hollow viscous perforation clinically were included in my study, and pediatric age group with patients with traumatic perforation and other intestinal perforation confirmed intraoperatively, and patients with malignancy were excluded. Relevant investigations were taken up, such as an erectixia abdomen showed in the picture with pneumoperitoneum, and patient was adequately resuscitated and taken up for emergency laparotomy. The picture on the left-hand side shows a perforation in the pyloric region, and the closure was done with closure of the was done with Grimes omental patch repair. This mucosa was sent for biopsy, and Giemsa staining is displayed. A 40x image of the showing microscopic image showing the clusters of Helicobacter pylori organisms. Coming to results. In the present study, the youngest patient was 30 years old and the oldest patient was 70 years old. So the mean age of incidence of peptic ulcer perforation was 48 years. In my study, about 70% were males and 30% were females who presented with peptic ulcer perforation. The present study, symptoms such as pain abdomen was present in all our subjects. Nausea and vomiting was present in 21 out of 30, constituted about 70% of my patients. NSAID history was taken and about 7 out of 30 patients, 23% had perforation. Pneumoperitoneum was found in all patients associated with axial bowel sounds and rigidity. The present study, other risk factors such as smoking, history, and consumption of alcohol was taken, and about 30% of the patients had history of alcohol consumption alone, and about 30% of the subjects had history of both smoking and alcohol consumption. In this study, the site of perforation was about 21 out of 30, 70% in the gastric region, and 9 out of 30, 30% in the duodenal. The present study, out of all the 30 patients with perforation in the gastric or duodenal region, about 76.7% patients had Helicobacter pylori infection, and they were identified with Giemsa staining. This graph in the table represents the presence of 14 patients out of total 20 in the gastric perforation. With the help of Giemsa staining, where 85.7% it was able to identify Helicobacter pylori infection, and in the duodenal region, 34.8% were able to identify with Giemsa staining. Moving on to discussion, in table 1, the Marshall and Warren observed 81% of peptic ulcer perforation. Helicobacter pylori was identified in gastric region and 100% in duodenal. In present study, 85% were in gastric and 34% in duodenal. In table 2, the mean incidence of age of presence of peptic ulcer perforation was at 48 years, which is comparable to the other studies. In table 3, the study shows 78.3% male preponderance with peptic ulcer perforation. In table 4, the need for eradication therapy was noted in 76.7% patients when compared to the other studies where presence of Helicobacter pylori and peptic ulcer perforation complications required eradication therapy after proper surgical treatment. Table 5 elicits the symptoms of peptic ulcer perforation such as pain abdomen, obstipation, absent bowel sounds, and rigidity of the abdomen with pneumoperitoneum, and 98% of the patients presented the same complaints. Table 6 shows that Ghosh et al., the author, has conducted studies on 404 patients, which showed that patients with low socioeconomic status had developed Helicobacter pylori infection. In the present study, since our setup is in the rural region, 76.7% of the patients had developed Helicobacter pylori infection. In table 7, the incidence of Helicobacter pylori infection in the present study was 76.7% when compared to the other studies within the normal limit. In table 8, Lofed et al., author, conducted study on 302 patients and studied that Giemsa staining gave accuracy of about 78% in identifying Helicobacter pylori infection. In the present study, 76.7% of the patient also we used Giemsa staining, and it was helpful in identifying Helicobacter pylori organism. Moving on to my conclusion. Gastroduodenal ulcer perforation still remains one of the most important cause of acute abdominal catastrophe with male preponderance. We conclude that Helicobacter pylori is an important factor in the etiology of gastroduodenal ulcer perforation and accounts for 77% of the cases, about duodenal perforation 34% and gastric perforation 85%. Our center is located in the rural setup where patients are from the low socioeconomic status, so the presence of Helicobacter pylori infection is more prevalent. All the patients diagnosed to have Helicobacter pylori infection post-surgery were started on eradication therapy to prevent relapse or recurrence of perforation. Hence, we conclude that Helicobacter pylori remain to be one of the most important causative factor for peptic ulcer perforation. Our study has used Giemsa staining as a method of diagnosing the presence of Helicobacter pylori in the mucosal edge biopsy study, since it was cost-effective to our patients and it proved of good results, albeit the sample size when compared to other studies. These are my references. Thank you.
Yeah, Sunil sir, the paper is open.
Yeah, good presentation again. Valid for the current state scenario. But one of your conclusion was cost effective. What was the cost of this testing?
So Giemsa
Extra cost
stain,
incurred by the patient for Giemsa staining.
Giemsa stain is easily prepared, and the
What
turnaround
was the
time is
cost?
5 minutes. So about 100 rupees, sir.
Because the common method used is rapid urease test, which is much cheaper. And
But
it is
our patients
easily
presented with
doable
perforation.
on spot, not necessary to really send to the lab and get it stained. So what was the reason for starting that Giemsa staining?
So our patients presented with perforation, sir. So the mucus biopsy was sent. So any low density or high density clusters of organism was easily picked up by Giemsa staining when compared to other.
Yeah, because that was missing in your slide, that the load was the
Load of bacterium.
morphology, different bacterial families or load was not mentioned. That's why I asked. Because only if to see presence or absence, rapid urease will do its job. That was what. And what was the length of the stay of all the patients? Is it the same?
So
Means
post-operatively about 5 days,
means
sir.
non-H. pylori patients were also there, is it not?
Yes, sir.
Were there
7
any
days.
difference between the morbidity or mortality? Did you notice anything like that?
So patients were who had Helicobacter pylori infection were already taking treatment for dyspepsia. So the length of stay was more for patients with that complaint. So rather than other patients, 7 patients who did not were tested negative for Helicobacter pylori.
Yes, sir. Good presentation. One question from my side. Did you try to find out if these patients were already on PPIs before they presented to you? Because if you haven't stopped the PPIs 24 hours before your testing for H. pylori, it might give you a false negative results. So any history of that in your series?
History was taken, so prior to surgery, whether they had any such dyspeptic symptoms and where they started on proton pump inhibitors. History was taken, sir.
So were they continuing on PPIs even when
No,
presented
no,
to you?
sir. When they presented to us, they were not on the PPIs.
Yeah.
Okay. Okay. And one more thing. What was your follow-up? Sorry, sir. Sunil, sir, please.
Yeah, no problem. Go ahead. Go ahead. Follow.
On your follow-up, did any of the patients come to you with intractable ulcer? What was your follow-up on this
The
series?
follow-up, patient was started on Helicobacter pylori kit for 10 to 14 days.
What was your eradication protocol in that?
So amoxicillin, clarithromycin, and proton pump pantoprazole. So it was given for 10 to 14 days. On follow-up, patients improved symptomatically. So no one had come back with intractable ulcer.
Okay.
The one basic question: what is your aim of presentation here? Means what is the main take-home message that you want to tell the audience about your presentation?
So peptic ulcer perforation due to Helicobacter pylori infection is still prevalent, and best cost-effective method it's better for Giemsa staining. So if in rapid urease test is not available.
Okay. Thank you.
One more thing which was surprising in your study was the isolates of H. pylori is more from the gastric than the duodenal, whereas it is vice versa in majority of the studies. Any sort of justification for that in your study? Or you mean to say that this is the shift, what you have presented?
Sure.
Any other comparable studies of your presentation?
So very minimal other comparable studies are there, sir. But many patients presented to us with pyloric and perforation. So most of it were gastric perforation in our setup.
Fine. Thank you.
Next presentation would be by Dr. Syed Saad, also final year postgraduate. He will be talking to us about necrotizing fasciitis in his paper. Lrinec score study.
Good evening, one and all. I'm Dr. Syed Saad, postgraduate from Department of General Surgery, Mvjmc and RH. I'd like to extend my thanks to the President and Secretariat of the Surgical Society, ME, as well as Dr. P. Sudarshan, HOD Sir and Professor Sir, for this valuable guidance in this paper, that is a laboratory risk in necrotizing fasciitis, an objective scoring system as a tool for early diagnosis of necrotizing fasciitis.
Dr. Syed,
Necrotizing soft, yes, sir.
a little bit loud, please.
Yes, sir. Necrotizing soft tissue infections have been recognized and reported, the earliest dating back to Hippocrates in the 5th century BC, when he had commented as many were attacked with erysipelas all over the body, with the exciting cause, which is usually a trivial accident. Flesh, sinews, and bones fell away in large quantities, and there were many dead. Such infections may range from mild pyodermas to life-threatening necrotizing fasciitis. Most commonly caused by streptococcal and staphylococcal species, but mostly of polymicrobial nature. Necrotizing fasciitis has been described in medical texts since 1871 and in surgical literature since 1924. The term necrotizing fasciitis was first used by Wilson in 1952. Since it is a part of the spectrum of necrotizing soft tissue infections, it poses as a diagnostic challenge. These infections often are mistaken for cellulitis or innocent wound infections. This may be compounded by the relative lack of clinical signs and symptoms in the earlier course of the infection. Surgical consultation is usually sought once the diagnosis is obvious and sepsis has already set in. Unfortunately, most adverse outcomes are due to this delay in diagnosis. In spite of advances in antibiotic therapy and intensive care, the mortality associated with necrotizing soft tissue infections remains high. The reported mortality is of 20%, which shows the inadequacy of the treatment due to delay diagnosis. Necrotizing fasciitis is a surgical emergency. It has a poor outcome after late operative intervention, but due to diagnosis difficulty. The laboratory risk indicator for necrotizing fasciitis was first introduced in 2004, and though many clinicians have commented on its usefulness, its validation still needs to be examined. The aim of my study was to use the scoring system as a tool for early distinguishing of necrotizing fasciitis from other infections of the soft tissue, to validate the risk categorization of the scoring system in distinguishing the types of necrotizing fasciitis, and to identify the significance in predicting the outcome. The prospective study included 60 patients in a 12-month duration in our institute from November 2020 to November 2021. Of those patients admitted in our ward with necrotizing soft tissue infections. The age, gender, clinical manifestations, site etiology, predisposing factors, comorbidities, vital signs, laboratory parameters, medications being taken at the time of admission, microbiology of wound, culture of pus, tissue biopsy, radiological imaging, and blood cultures had been recorded. Aggressive surgical debridement, antibiotic therapy, treatment of complications, amputation, or skin grafting were strategized for management. All variables were noted and statistically analyzed, along with its significance with respect to the scoring system. Inclusion criteria is all patients with severe soft tissue infections. The inclusion criteria were patients referred from other institutes with already diagnosed necrotizing fasciitis, patients who needed multiple admissions following the initial diagnosis of necrotizing fasciitis, patients with surgical site infections, and patients who do not give consent for the study. This is the laboratory risk indicator of necrotizing fasciitis, which shows 6 components. That is, a CRF more than 150 are considered to give a point of 4, white cell counts of more than 25 is point of 2, and between 15 to 25,000 as a point of 1. Hemoglobin of more than 11 to 13.5 a score of 1, less than 11 a score of 2, sodium of more than 135 a score of 1 and less than 135 score of 2, creatinine of more than 1.6 was given a score of 2, and a glucose of more than 180 mg per deciliter of 1, with the maximum score of 30. Spontaneous onset of the disease, and 22% had shown a preceding event such as a minimal trauma, such as a nail break or otherwise even road traffic accident. In this study, majority of my patients were male, and less patients were female, in which males in low, intermediate, and high risk group were 31, 5, and 6. And in the female patients, low was 14, intermediate, and high were 2 each. There is no statistical significant difference between the mean age groups of the three groups, with the mean age of 55.3. For all the comorbidities, diabetes mellitus was considered to be the most frequent predisposing factor for necrotizing soft tissue infections, with 23 patients with diabetes mellitus and 5 patients with chronic renal failure and 3 with systemic hypertension. Of the 7 of the 8 patients in the high risk group, sorry for that. 7 of the 8 patients in high risk groups were diabetics, 12 and 4 patients were diabetics in the low and intermediate risk groups. In my study, that is, of the 45 patients in the low risk group, 22 had improved with IV antibiotics and minimal debridements. 23 required surgical debridements in serial manner, and of those, skin grafting were applied and 8 are successfully taken up. On the 7 patients in the intermediate risk group, there were no morbidity and mortalities with IV antibiotics and surgical debridements. 3 of them required split thickness skin grafting. In the high risk category of the 8 patients, 3 improved with surgical debridement and split thickness skin grafting, 2 required amputations, and 3 had died despite all resuscitative measures. Comparing the same, among the diabetic patients, there were 12 in low, in which all improved with IV antibiotics and minimal surgical debridement. In intermediate group, all 4 improved with antibiotics and surgical debridement. In the high risk group, which constituted 7 of the 8 patients that were categorized here, most of them diabetic, 3 had died, 2 required amputation, and 2 required surgical debridements with split thickness skin grafting. The limitations of my study were that the clinical outcomes could not be outlined because of the limited population included in the study. Further studies were required to determine if additional interventions could have helped the high mortality risk group. The conclusion is, in my study, more than a Lrinec score of more than 6 has shown a better sensitivity and specificity in identifying necrotizing fasciitis, and the scoring system has a better sensitivity and positive predictive value in identifying the onset and risk strategizing of necrotizing fasciitis, and this aiding us in our treatment. And the scoring system is also readily available in all primary and secondary centers and helps us distinguish the severity of the soft tissue infection. This is one patient of ours which had come in the casualty with necrotizing fasciitis of the right lower limb. Following 2 weeks of continuous debridements, this is the middle picture showing a healthy granulating wound, and the picture on the extreme right shows a post-op day 3 of good uptake of a split thickness skin graft. In the discussion, necrotizing fasciitis is a well-defined, persistent, and pervasive disease in which the fascia is the primary site of infection. It is usually present in 0.4 people per 100,000 population per year. They are among the most common infections occurring in the groups of mortality between 16 and 45%. Hard clinical signs such as crepitance, bullion necrosis, and subcutaneous air on radiography, which helps us establish the diagnosis, usually apparent in only 40% of the cases. The mortality, just shown by Bilton et al., really compared to our study, shows the early treatment showed a mortality of only 4.2%, as was in our case of 5%, with delayed treatment showing 38% of mortality. Swain et al. Clearly showed that those people with a Lrinec score of 6.5 survived as compared to our study of 6, and those with a Lrinec score of 9 had a higher mortality compared to our study of 9.5 having a higher mortality. And also the score showed that the highest associated comorbidities have been diabetes, hypertension, obesity, and hypercholesterolemia, with a similar comparison to our study showing the association of diabetes mellitus with the onset as well as the increased morbidity and severity of the infection. However, Lrinec score has a poor sensitivity and should not be used to rule out necrotizing soft tissue infections, as well as the scoring system can be used as an adjunct to the management of soft tissue infections in secondary care hospitals and may prevent delayed referral to tertiary centers where a better opportunity for his survival will be there. These are my references. Thank you.
Yeah, good presentation, right?
Thank you, sir.
One question in your exclusion criteria, you excluded the outside diagnosed necrotizing fasciitis. Why?
Yes, sir. I did that to prevent any biases that would happen in my approach to the patient, sir. Having said that, when I had used my scoring system on any patient that had presented newly to my to the hospital, I could expressively use it as a kind of a blinding, so that I would approach it based on what values I would get. But however, if the patient was referred from outside, I would always have that idea of saving the patient, of doing the best I can to save the patient, and go for an early, more aggressive surgical treatment, as well as better care after post-operatively.
No, why I'm asking is this,
Yes,
this score is basically a risk stratification
Yes.
to tell about the clinical outcome, or rather you can tell the prognosis of the patient.
It gives us both as a diagnostic approach as well as
Yeah,
risk
yeah, I
stratification.
agree with you. But outside diagnosis means it is not related to diagnosis at all. So you are only seeing the parameters. You are not at all seeing the diagnosis or the duration of the stay. Nothing like that. So since it was little
Duration
surprising
of the
to
stay was,
see. Yes.
sorry, sir. The duration of the stay was evaluated, sir, and those of the low risk group were actually shown to have only a requirement of 4 week or less than 4 weeks stay in the hospital. Those of high risk group even required sometimes up to 12 weeks. A patient that had passed away actually required up to 4 months of treatment, sir. Therefore, because of the bias, I'm not included.
Yeah, many studies are there on this score. Anything new you did in this study of yours?
There was a study by Hamoud and Worm et al., sir, which showed that the use of MRI adjunct with Lrinec scoring showed a higher possibility of you diagnosing it as necrotizing fasciitis, sir, which was an improvement on the already present Lrinec scoring system. But because of a multivariate analysis in 2020 that had questioned the still continued requirement and use of the scoring system, I thought
I
apply
am
this to
stressing again.
Yes.
Sorry to interrupt. I'm stressing
Sorry,
because the diagnosis here is not important.
Yes,
Means it's not a diagnosis that we miss often, and to diagnose it, we need more scores. It is more of a risk stratification, as you already told.
Yes, sir.
Because one of your discussion studies you quoted, they saw more of obese people getting into the risk group. So was something like that BMI calculated in those patients, and saw obesity is a risk factor, because diabetes, we all know that it is a risk
Yes,
factor.
sir. As a general basis, we had taken the nutritional status of the patient into account, sir.
For the study, you took or you didn't?
On just as a general data collection, sir. But however, we could not find any direct correlation between obesity and risk, so was not mentioned.
Thank you. One of my questions was already asked by Sunil sir, so no questions from my side.
Coming. On the line now.
Please.
Thank you very much.
Thank you, sir.
Thank you, Syed. And respected sirs, that concludes the paper presentation from MBJ Medical College. Over to Dr. Nagbhushan.
Hello, good evening. Our first paper will be presented by our resident, Dr. Rohit Devani. His will be on our experience of laparoscopic hybrid mesh repair in difficult ventral hernias. On to you, Dr. Rohit. A very good evening to one and all. I'd like to thank our staff, Dr. Mvjmc sir and Dr. Nagbhushan sir, for giving me an opportunity to present the paper on our experience of laparoscopic hybrid mesh repair in difficult ventral hernia. Laparoscopic ventral hernia has gained popularity since it reduces the post-operative morbidity and hospital stay compared to the open approach. In our institute, majority of the incision hernias are repaired laparoscopically by IPOM plus approach, which includes adhesive lysis, intracorporeal defect closure and IPOM composite mesh placement. In certain incision hernias, there are challenges for repair of the laparoscopic ventral hernia repair, which includes morbid obesity, large sac in large incarcerated hernia with extensive adhesions. We hypothesize that in these situations, a hybrid laparoscopic approach adds an advantage for this. A total of 187 patients underwent laparoscopic ventral hernia repair in our hospital from January 2018 to January 2022, out of which 16 patients underwent laparoscopic hybrid hernia repair, and forms the basis of the study. A retrospective review of patient demographic, intraoperative and postoperative data were collected and analyzed. Methods: patient demographic includes gender, age, BMI, prior abdominal surgeries, comorbidities. Intraoperative data include defect size, number of the defects, ideolysis, mesh size, type, and operative time. Postoperative data included epidural anesthesia, complications, length of hospitalization, recurrence, seroma formation, and surgical site infections. First methods. In that first method, what we used is we do a ideolysis laparoscopically, open the sac, excise the excess sac, and we close the defect, and we place the mesh by laparoscopic approach. Another approach is do open surgery, do ideolysis, excise the sac, close the defect, and do a laparoscopic mesh placement. But we routinely use the first method. Surgical technique: initially through laparoscopic approach, open ideolysis, we close it. Open ideolysis was done, followed by laparoscopic mesh fixation. Laparoscopic ideolysis was performed first to maximal extent feasible. A short incision was made over the sac and the large defect, and ideolysis was completed. A sac was excised completely. Ball was inspected if necessary. Facial approximation was done by Smith-Jones technique. Then after closing the defect, before then the mesh was introduced either before closing the fascia or later at laparoscopy. A composite mesh was used in all the cases, and overlap of 5 cm from all the defects was ensured. Minimal extracorporeal mesh handling was ensured, and soiling of mesh was avoided. The mesh was anchored with transfacial sutures and the tackers. Slide change. Patient demographic: total of 16 patients were included in our study, out of which 10 were female and 6 were male. Mean age was 57 years and BMI was 29.3 years. Prior surgery was seen in 11 patients with a single surgery who had undergone, and 4 patients had undergone multiple surgeries. Comorbidities were seen in 9 patients and multiple were seen in 5 patients. Intraoperative data: mean defect size was 40.53 centimeters square. Number of defects: single defects were seen in 12 patients and multiple were seen in 3 patients. Ideolysis was done in all the 5 patients. Mean operative time was 4.3 hours. And mesh size were the following, which included 15 to 50 and up to 20 to 20 centimeters were used. Mesh type was Paratex, Symbotex, and Prolene were used. In that, all the 16 borderline hernias, 4 were borderline hernias. In 3 patients, epidural anesthesia was required. Mean length of hospital stay was 4.8 days. Follow-up period was 2.4 years. Seroma formation was seen in 1 patient and chronic pain was seen in 1 patient. Our results have shown in difficult laparoscopic ventral hernia repair, hybrid technique has no recurrence during the observation period, no complications like bowel injury, wound infections, lower incidence of seroma formation, compared to laparoscopic surgery for postoperative stay and pain. Our results have shown that hybrid method of repairing difficult ventral hernia has the following advantages. Since the majority of the intra-abdominal ideolysis has been already done laparoscopically, a short incision over the defect suffices, reducing the surgical insult, reduces the incidence of conversion to completely open surgery, avoids the large skin flaps. Large defect up to 10 cm can be managed. and there is low incidence of seroma formation. Ability to perform the adolescence under vision and infect for bowel for any injuries, reduce the length of the operating time, close the defect adequately and ensure facial approximation. Large mat can be comfortably placed intraoperatively, that is a composite mesh. Could reduce the incidence of recurrence in these challenging subset of patients when compared to the pure laparoscopic repair. Lower incidence of complications like enterotomy and wound complications can be reduced. Has a role in obstructed patients. So we have a case report. A patient of 52-year-old male who underwent liver transplant 4 years back developed incision hernia with subacute intestinal obstruction, was managed conservatively and was taken for surgery. We have one short video, sir. First is the preliminary. Restart.
Eight, huh? Doctor, 7 minutes are up.
Yes, this is a video where defect size of 6 into 8 centimeter incision hernia was manipulated for adolescence, sir, and rest of the ball was stuck in the defect. So we couldn't do a further dissection. So we took a small incision over the defect, sir. We did rest of the adolescence and contents were reduced. Defect was closed and mesh was placed intraperitoneal, sir, through laparoscopic approach.
Yeah. Thank you, Doctor.
Yes, sir.
Good
These are my
presentation.
references, sir. Thank you.
Yeah, it's okay. Yeah.
Thank you very much. The paper is open for discussion.
Yeah. Am I audible?
Yes, sir.
Yeah. I am confirming that this is a case series. Not
Yes,
a
sir.
study.
Yes, sir.
Yes. Okay. Yeah. Fine. You have the main aim is to see difficult cases and go for hybrid technique.
Yes, sir.
But what were the measures? What were the parameters you saw to tell it is difficult case? It's
sir,
quite subjective, is it not?
Yes, sir. It is a subjective, sir, and mainly when adolescence is difficult, sir, rather than converting into open, just take a small incision, sir. We try to reduce the contents of the hernia, and if any excessive sac is there, we excise it, close the defect, and place the mesh intraperitoneal through laparoscopic approach, sir.
So can I take that it is a dense adhesions?
Pardon,
or
sir?
irreducible hernias with dense adhesions, something like that?
Yes, sir. We can do that, sir. Even for
in one of your comparisons, you told large skin flaps are raised in open, so this is comparatively better.
Yes,
but
sir.
Nowadays, yeah, that is onlay repair you are comparing with. But nowadays, onlay repair is very rarely done.
Yes, sir.
More of pre-peritoneal or retrorectus repairs are done. So
Yes,
there are no flaps. So it was not wise to compare with a skin flap and a laparoscopic technique. That was one comment.
Yes, sir.
Yeah, Dr. Khan, anything?
Yes, sir. Thank you. Good paper, but of course, like as Sir said, it's more of a observational study.
Yes, sir.
Where you lack follow-up on the recurrence and post-operative complications.
Yes, sir. But in our study, we try to follow up with the patient, sir.
What was the follow-up period?
Follow-up period was 2.5 years, sir. Mean follow-up period was 2.5 years.
And what were your observations on that?
Sir, there was no
Regards
recurrence
to recurrence, mesh infection, or be it pain?
Sir, one patient had chronic pain. Apart from that, we couldn't No patient complaint of any recurrence or any recurrence was not seen in any patients, sir.
Did any of your patients had loss of domain?
No, sir, that was not fit for this thing, sir, laparoscopic approach. And
okay. And another question is, you said even defects up to 10 centimeters could have been managed efficaciously with this technique. So intraoperatively, how did you decide that there was no tension on the suturing of the midline?
Sir, after reducing the contents of the sac, hernia sac, sir.
Now, how did you decide that there is no tension on the suture line?
Sir, intraoperatively you are talking about, or?
Intraoperatively.
Yes, sir. After suturing, if there is no adequate approximation of the fascia, sir, then we can.
Approximation can be done with tension also, but
yes,
the question is specific. How did you decide that there's no tension on? Because the main cause of recurrence is tension.
Yes, sir.
The one is obesity. I think the cutoff in your study was 37.13, the BMI.
Yes, sir.
Right. So a few patients were obese also.
Yes, sir.
Fine, not an issue. Any ERAS protocol was implemented in your study?
Sir, pardon?
ERAS protocol, was it implemented in your series?
No, sir.
Okay, thank you.
Thank you, sir.
We'll go for the next paper.
The next paper will be presented by Dr. Shruthi Rachita. She will be talking on her interim results on her ongoing study in relation to the factors affecting the surgical site infection. On to you, Dr. Shruthi.
ಇದು ಆಫ್ ಮಾಡಿ ಡಿಸ್ಕಷನ್ ಶುರು ಮಾಡಿದ ತಕ್ಷಣ before we go to the announcement of the awards, we will have some announcements. Let us finish the announcements. So please, first next monthly ಹೇಳ್ತೀನಿ ಆಮೇಲೆ we have a condolences and request to the students. ಹೇಳಿ ಸರ್ ನೀವು.
Is she okay to start the presentation?
Please go ahead.
Good evening, everyone. I'm Dr. Shruthi Rachita, second year postgraduate from BGS Global Institute of Medical Sciences. I would like to extend my sincere gratitude to the President and Honorary Secretary of Surgical Society of Bangalore, including Dr. Nagbhushan sir and Dr. Neil Shetty sir. I would also like to extend my thanks to my head of the department, Dr. Madan sir, and my moderator, Dr. Shrikant Kulkarni sir. My paper is on the factors influencing surgical site infection. It's an ongoing prospective study in my college. Coming to the introduction, surgical site infections account for 20% of healthcare acquired infections, and they cause significant morbidity, and also hospital costs are increased. In India, the incidence varies from 3.6 to 22.5%. There is an estimated annual incidence ranging from 1,60,000 to 2 lakhs, with an annual cost of surgical site infections in the United States estimated to be somewhere from $3 lakh to 10 billion. In the current era of antibiotic resistance, with no new invention of any antibiotics, it becomes crucial to determine the factors responsible for the surgical site infection. This is a prospective observational study with objectives being the primary objective is to study the incidence of surgical site infection in our hospital, And the secondary objective was to identify the risk factors contributing to the surgical site infection. The study setting was in the Department of General Surgery in Ggh&Gims. The sample size taken was 50. The duration of surgery was for 6 months. The inclusion criteria being all patients above 18 years undergoing surgery in the department, which included superficial, deep, and organ space infections which developed later. Exclusion criteria is any patient below age of 18 years and any previous surgeries at the same site, and patients failing to come for follow-up for 30 days after the surgery. The sampling procedure is all the patients above 18 years who required surgery were enrolled in the study, and each patient was followed up for a period of 30 days. The surgical site was inspected for symptoms and signs like erythema, swelling, induration, localized rise of temperature, and purulent discharge from the surgical site following surgery. If the surgical site got infected, then culture and sensitivity, and if needed, blood culture and ultrasound of the area was done. The surgical risk factors for surgical site infection being considered in my study are age, factors like anemia, hypoalbuminemia, concurrent diseases like diabetes, malignancy, immunosuppression, use of antibiotics, duration of stay in the hospital, duration of surgery, and the use of a drain. Coming to the results, here we can see that the major number of cases that we were admitting came in the age group of 21 to 30 years. But however, the maximum number of SSIs was seen in the age group of 41 to 15 years. This was mainly because the increased number of comorbid conditions that the patient had, and also due to less immunity. The type of wound that that showed maximum amount of SSI was the contaminated surgeries, which showed up to 25% of the surgical site infections. The type of surgery here, surprisingly, we have more number of cases in the elective surgeries, that is up to 62.5%. I would like to highlight here that we have more number of elective admissions than emergency admissions, and hence the difference from other studies that are conducted. The duration of surgeries, as the duration of the surgery increased, the incidence of surgical site also increased. In my study, whenever a surgery was prolonged for more than 2 hours, the incidence of surgical site infection also increased by 23%. The usage of surgical drains also increased the incidence of surgical site infection. Out of 50 patients, drain was inserted in 25 patients, out of which 6 patients developed surgical site infection. In a study conducted by Khan et al. And Kamath et al., in which the incidence of surgical site infection in patients with surgical drain was 30%, and with no drain was 11%. The risk factors, the main contributing risk factor in comorbidities was anemia, where out of 27 patients, 7 patients developed surgical site infection, followed by malnutrition, obesity, and diabetes, followed by smoking and alcoholism. The level of SSIs, we had 5 superficial surgical site infections out of 50 patients, and 3 deep surgical site infections out of 50 patients, and we did not encounter any organ space infections. I would like to highlight here that a study conducted by Seresky et al., which showed 83.46% of infected surgical cases were superficial SSI, and 11% were deep, and 5.5% were organ space. The first image shows superficial surgical site infection here, and the second one shows deep surgical site infection. Coming to the antibiotic prophylaxis, out of 50 patients, 46 patients received antibiotic, prophylactic antibiotic according to our hospital antibiotic policy, and 4 did not. Here, I would like to highlight that 17.39% patients developed SSIs despite of giving prophylactic antibiotics. And retrospectively, when it was seen, most of the patients who developed SSIs here had contaminated wounds. The development of SSI, most commonly the patients presented on day 4, followed by day 5 and day 6. The most common organism isolated was E. coli, which contributed to 37%, followed by Klebsiella, Pseudomonas, and then Staphylococcus aureus. The hospital stay, the mean hospital stay for patients who did not develop SSI was around 7 days. And for those who did develop, it was around 17 days, which contributed significantly to the morbidity of the patient. Coming to the discussion, the overall infection rate were 8 out of 50 cases. The incidence rate in this study goes well with the other studies that were conducted, which have about 2.8 to 17% in other studies. Majority of the patients belong to the age group of 41 to 15 years, and 14 patients had appendicular pathology, accounting to about 28%. Appendectomy was the most common procedure performed. However, complicated appendectomy shows higher incidence. Increase in duration of surgery increases the SSIs. In about 50% cases, post-operative DANE was inserted, out of which 24 patients, 24% had SSI. Anemia was the single most common risk factor, accounting, followed by malnutrition, smoking, and alcohol. Elective procedures in my study, where 78% of the patients showed higher incidence of infection. Higher incidence of SSI is seen with increased contamination of the surgery, and pain at post-operative site and serosanguinous and purulent discharge are the most commonest mode of presentation, and post-operative day 3 to 6. Midline incision accounts for higher incidence, and superficial infection is the commonest type of SSI. E. coli contributed to the maximum isolated organism. I would like to conclude by saying that periodic surveillance of SSI will guide the Infection Control Committee in laying down strict guidelines to further decrease the SSI incidence in our setup, which is an indicator of healthcare system. Here are my references.
Thank you, doctor. It was a good presentation. SSI is never dying subject. It is going on a lot of research. Good to know. Only few comments. In the results part, you discussed other studies, but in the discussion, you put your results and there was no conclusion. You should have added the slides. That was general statement. Okay, anyway, in your results, you found anemia was one of the risk factors for all the SSIs, is it?
Yes.
And most of the surgeries, as you told, were elective. I assume that you would have corrected the anemia before surgery, optimized the patient, and then did the surgery. But still, you found anemia was one of the risk factors.
There are also studies which show that blood transfusion itself increases the incidence of SSIs.
Okay, but you should have quoted or at least told some references. Because if you are told that it was an emergency procedure where you don't have time to correct the anemia, yes, agreed. But you stressed the point that most of them were elective. And in one of the slides, you also showed that duration of surgery was the more the duration, more the SSI. But the same slide also showed less than 1 hour surgery. Also, the SSI was 3, and more than 3 hours, 2 hours was also 3. But you took only one part of the table. Okay, fine. Dr. Khan?
Yes, sir. Thank you. Good presentation, more of an observational study. One question, you have mentioned that midline closures had higher surgical site infection. Can you substantiate how and why?
Some more of the midline surgeries which had the patients in my study, the comorbidities were high, sir. And also the patients coming under midline closures, the emergency surgeries were high. This was retrospectively when the data was analyzed.
Thank you.
So if no more questions from the judges, shall we end the session?
Yes, sir. Thank you.
Yes, sir.
Thank you. So before we will announce the winners, there are few announcements to be made. The first announcement is that we'll have the monthly clinical meet for the March, which will be hosted by Manipal Hospital on 16th March 2022. The venue will be intimated soon, and it will be an offline program. And now,
from now onwards, the whole year, we are thinking of doing each and every program offline. I request all the HODs and all the respected members of the Surgical Society Bangalore to cooperate with us. Unless there is a information by the government not to do offline, we are going to do offline. Thank you very much.
Thank you, sir. And continuing with this, just 1 second. So first is that we have a condolence. It is to our late Dr. Sampath Kumar, BT Sampath Kumar, who was the life member of SSB, and he was a past president of SSB from 1994 to 1995. He passed away on Sunday, 30th January 2022, and it's a big loss for the SSB. He has been achieving many accomplishments, like he was the first urologist in Bangalore, and he was the first person to start the MCH program at Bangalore Medical College, and he was the founder of Urology Society of Bangalore. He was a promoter director of the Bangalore Hospital. We want to offer this, and he was, as I mentioned, he was the president of the Surgical Society of Bangalore from 1994 to 1995. And as a mark of respect to the departed soul, we will now observe 1 minute of silence.
Thank you, everybody.
Thank you all. And if there is anyone who wants to speak few words on our Dr. late BT Sampath Kumar, can please speak up now. Okay, so we will just go to the next one. We have some good news also to be shared today.
Happy news.
Happy news. Please, sir. So the first one is, it is our past president of our SSB, Dr. M.K. Ramesh, who recently took over as a Vice Chancellor of Rajiv Gandhi University of Health Sciences. He was the president of our Surgical Society of Bangalore from 2014 to 15. And he was the past president of the PG board of the National Medical Council from 2020 to 2022. And it's a big prestigious occasion for SSB that he has taken over as a Vice Chancellor of one of the biggest medical universities of India. And we from the SSB Surgical Society of Bangalore, we went and congratulated our Professor M.K. Ramesh, sir. Congratulations, sir. And next we have another very good news, a very happy news is that our Dr. H.V. Shivaram sir has been elected as the chairman-elect of Karnataka State Chapter Surgical ASI, and who was our past president from 2013 to 2014. And he's even EEC member of the ASI also, and he's head of Department of Surgical Sciences at Aster, Bangalore. It's a very happy news that sir has been, he won the election with a huge margin, and it's a very happy news for us. And we did even honor our Dr. H.V. Shivaram sir for on this achieving this another milestone. And finally, we want to congratulate even Dr. Nagesh NS, who is the founder director of IGOT, that is Institute of Gastroenterology Sciences and Organ Transplantation, for being elected as the treasurer of Indian chapter of AHPPA. Congratulations, sir. So thank you all for hearing to the good news. And so now coming to the much awaited announcement of the winners, I request our Mr. President to please announce the winners for today's session.
Okay, let me announce the winners of today's poster and paper presentation. The second poster presentation today is malrotation with a twist, Dr. Suhas L, MVJ Medical College. Congrats, Dr. Suhas. The first paper, the poster, first prize goes to carotid body tumor, a challenging lateral neck mass. Dr. Rehna Begum, BJ's and Giemsa Hospital. Congratulations, doctor. Coming to the paper presentation, the first paper presentation goes to Dr. Akhila K for Giemsa staining of Helicobacter pylori infection in peptic ulcer perforation from MVJ Medical College. And second, the prize goes to Dr. Shruthi Rachita, BJ's and Giemsa Medical College, for the paper factors affecting surgical site infection and ongoing prospective study. Both of you, congratulations.
Congratulations to all the winners. Now I would like to thank Dr. Sudarshan sir, the HOD of MVJ Medical College, and Dr. Nagmushan sir, for HOD of BJ's Global Hospitals, for hosting this wonderful academic session. Thank you, sirs. And I would like to thank the judges for today, that is Sagar for the posters, Dr. Sunil Kumar, Dr. Hosni Mubarak Khan for the papers. Thank you, judges. And thank you to Dr. Sudarshan B, our EC members for MVJ Medical College. So,
Dr. Sudarshan Nambushan, very well done. All the papers were very good.
Thank you, President and Secretary. Thank you.
You have taken very, lot of effort to get the PGs doing well. They all did well. Okay, the papers were also very good. We request you to continue the same thing. Only thing we missed is, don't take it to heart. We missed the, offline mode and food and beverages and meeting in.
Oh, we will join up. We will join up.
15 PGs were, deprived of coming on the stage and presenting. Okay, next year is always there. Okay. We request your support in future monthly clinical meetings, and please tell your PGs to register for our society, and please tell them to attend in all the monthly clinical meeting teaching programs. And I request you people also, all the consultants, you HODs of BJS also, please attend all the monthly clinical meeting. Thank you very much. It was a very nice monthly clinical meeting today. Thank you very much.
It was offline, but the information was too late that we couldn't manage. And I must thank Dr. Nagaraj to be my participant also. Thank you, Dr. Nagaraj. Yeah, Chalta. Yeah, we will all join up. Thank you. Thank you very much.
Thank you very much.
Okay, thank you, Mr. President. So we come to the end of today's monthly clinical meet. And as usual, we will end it with the national anthem. So I request all the members to please kindly stand up for the national anthem. Thank you all.
Volume.
Thank you all.
Thank you all.